Hi, I'm Diana Saville. I'm the president and co-founder of BrainMind, and we're here with Dr. Richard Isaacson, and we're going to be talking about how he is revolutionizing brain health care. So Richard, would you care to introduce yourself a little bit?
Sure. So my name is Richard Isaacson. I'm a preventive neurologist, and for those of you who have not heard that term before, it's really, I'm a neurologist that focuses on preventing neurological disease. Most brain disorders, Alzheimer's, Parkinson's, Lewy body dementia, among many others, start in the brain decades before symptoms, and it's our job to try to figure this out before symptoms begin so we can have an early intervention plan. I currently direct the Institute for Neurodegenerative Diseases in Florida and focus my work on brain health.
So can you tell me a little bit more about how your work is different from a typical brain health center?
Sure. So, the field of preventive neurology is one that doesn't exactly exist yet. There's only a handful of neurologists in the United States and abroad that think about this or practice in this way. But really, this has to be the future. We're a sick care medical system, and I think our goal is to transition to a well care medical system and a preventative health care system, because if we try to treat a disease that's been going on for decades, the progress and the impact is just going to be minuscule. If we can treat a disease that's just starting before symptoms begin, prevention to me is a cure. And when you really are moving towards the goal of the holy grail of preventing neurodegenerative disease, you have to start decades early. So our goal is to see people before symptoms, people with a family history of Alzheimer's, Lewy body dementia, Parkinson's disease. And then also our goal is to study all of these somewhat related but not exactly related conditions in the same way, in the same group, in the same research structure, so that we can compare the trajectories of each patient and we can compare various markers in the blood over time in these individual groups.
And your work is very data-driven. Can you talk a little bit about how you leverage data?
Sure. So, in the past, we would say exercise, eat a healthy diet, Mediterranean-style diet, get your sleep, modify stress. And we would tell people to do this, and they would feel better. And we would check their cognitive function, and their cognition would stabilize or improve. And their biomarkers, their cholesterol, their nutrition markers would also look better, so we felt like we were making an impact. If you can impact a person's modifiable risk factors for brain disease or neurodegenerative disease or cognitive decline, biomarkers like cholesterol, insulin resistance, nutrition markers, inflammation, if cognitive function is also improving or stabilizing, that means we're having an effect. But the holy grail with neurodegenerative disease prevention or risk reduction is, can we actually impact the disease pathology that we're trying to target? So our group has really pivoted quickly and strongly towards using blood-based biomarkers. Most people don't think that there's a way to diagnose Alzheimer's disease or Lewy body or Parkinson's disease from a blood test. I would disagree. Yes, there are fancy tests like PET scans and spinal taps, lumbar punctures, looking at the fluid that bathes the brain and having to do more of an invasive procedure. But the future to me of Alzheimer's, Lewy body, Parkinson's disease prevention are really going to rely on blood testing and using what we call proteomics, which is looking at very small amounts of protein in the blood. We spin the blood down, we freeze the blood, we put it in a what we call a biorepository, so we can store the samples for decades, literally. As new tests are developed, we can always go back in time to understand where the person was at and then what the trajectory of change was over time. What we do is we look for these markers, something called amyloid protein. It's a sticky protein that builds up in the brain of Alzheimer's patients, as well as Lewy body and other patients. We look at a protein called tau. We look at a protein called alpha-synuclein in different forms, phosphorylated versus oligo-alpha-synuclein. Numbers here are complicated. The metrics here are complicated. And then we look at really non-specific markers, something called neurofilament light. We've been looking at neurogranin and neurofilament heavy chain, and there's all this gobbledygook. But the goal of our work, and really the goal of the projects that BrainMind has supported, that we would have never been able to do without the support, it's just too high risk, high reward, but also way too high risk, is to try to develop what we colloquially will call the cholesterol test for the brain. Just like everyone, every year or two, gets a total cholesterol and HDL cholesterol and LDL, the bad cholesterol, and triglycerides, we want to do the same thing for brain disease. And when we're going to be, hopefully in the coming years, and we kind of do this now, but hopefully it'll be ready for prime time soon, everyone's going to get that amyloid level, the various p-taus. People that are at higher risk for Parkinson's or Lewy body will get a alpha-synuclein in different types in the blood, and we'll be able to get a baseline. And then when something starts changing over time, we can then intervene in a personalized way. And then what we can do, this is again our goal, and we've published on this just a little bit, what we've shown is that when we can actually give people a targeted plan based on the proteins we find in their blood, based on the risk factors that they have, and based on their family history, in our biorepository we can track change. So yay, cognition's improving, yay, their cholesterol's improving. But we've also now shown statistically significant improvements in both amyloid and tau protein, the biological hallmarks of the disease, across the entire group as a whole. And that was something that actually shocked me. And we just presented that at the American Academy of Neurology meeting. We'll be presenting that at the Alzheimer's Association International Conference this summer.
So you mentioned these projects that BrainMind supported that you wouldn't have otherwise done. Could you expand more on that?
There is no part of our work that is fundable by traditional means. There is no NIH grant that I could apply for right now, or there's very few foundations that even think this way. But most grants that you apply for take 6 months, 9 months to get a review, and then you have to go back in and make changes. And then by the time you submit the grant to have the final disbursement of the funds, it could be a year and a half later. And a year and a half in our field, way too slow. I mean, things are moving so rapidly. Last summer I saw, wow, interesting machine. Wow, interesting technology. I'm going to apply for a grant for this. Well, it'll take a year and a half, and by that time, everything will change. So we pivot quickly. We have funding, we use philanthropy, we use foundation funds, and we go and we move. And in some ways, it's kind of like you have to have like a entrepreneurial spirit when it comes to research, and you kind of also have to have more of like a venture philanthropy kind of mindset, where you make a big bet on a new technology or a new path forward, and without doing that, there would be delays, there would be loss of opportunities, and using BrainMind's funds, we've been able to take really big risks that traditional funders, aside from not having like a funding request that you can apply for, because this stuff just doesn't exist in this type of population before a person has symptoms. That's the clincher here. There's lots of grants you can get when someone already has dementia. When someone already has dementia, they've had that disease for literally decades. We're looking at the children and the family members of people with cognitive decline and dementia. We're also looking at the people with dementia, and we follow families. And there's just no grants or no mechanisms to support that. BrainMind's allowed us to be visionary, to take big risks. Some would say too big risks. How could you spend that much money on this big idea? Well, so far things are working, and I can't guarantee that everything's going to work. And we are definitely taking big risks on technology that isn't really entirely proven, never been done in humans before, never been done in people in their 20s, 30s, 40s, young people where they may have minuscule amounts of protein in the blood that maybe we won't even be able to detect. But we're going to take a big bet. We're going to use new technology. We're going to use ways to amplify proteins that have never been used before, and also in tiny amounts to make it more accessible. Our goal is to democratize access to brain health care. And if people have to go and pay thousands of dollars for a PET scan that has radiation, a brain scan, if people have to go in and get a procedure, a spinal tap, that's going to limit access. And our goal is to use blood tests. And eventually our goal is to use at-home testing, and we're really trying to pioneer at-home fingerprint card testing. And these are still early days, but I'm really excited. And if we could use the right machinery, amplify the proteins, use tiny amounts of blood, and then package it with an offering where people have access to education, to information, and to guidance about their individual risk factors, that's the way we're going to reach people. That's how we're going to scale, and that's how we'll democratize brain health care.
So some of your work functions like a clinic, but there's also an entrepreneurial aspect to your work. Can you talk about the different workflows there?
Yeah, sure. So I'm a neurologist. I'm a clinical neurologist. I have a very small clinical practice, and the patients that we see get very deep, very attentive, very hands-on, personalized care based on emerging principles of precision medicine. We're going to look at deep phenotyping. We're going to look at blood biomarkers. We're going to get detailed neurocognitive testing. We're going to look at body composition measures, brain MRIs with volumetrics. We are going to characterize the person sitting in front of us in every way, shape, or form. At every time point, we're going to look at also these new emerging blood-based biomarkers of neurodegenerative disease, and we're going to track these people entirely precisely and closely. People will get comprehensive plans, again, based on emerging principles of precision medicine. That's not scalable, but that's our feeding ground. That's our learning ground to really understand what is the minimum amount of data that we need to get to be able to provide this access to care in a democratized fashion at lower costs, at broader scale. So in a typical clinic setting, I'll see one patient in a day. We'll spend hours, dozens of hours, on that one patient discussing with a team of multidisciplinary experts. I'm a neurologist, but we have a preventive health physician, family practice, nurse practitioner. We have consultants across basically every sphere of medicine, psychiatry, neurology, psychology, and primary care. Also cardiology, everything, endocrinology. We can then learn from that as our prototype. And then what we try to do is democratize access in two ways. And this is really where I think the entrepreneurial spirit comes in. Number one, how do you reach people? Well, one way to do that at scale is to use software. And what we've done is created a digital therapeutic or automated software solution that includes basically anyone with a cell phone can access a risk assessment funded initially by the NIH and then other funding afterward, a risk assessment online, then using the phone can do cognitive assessments, and then based on what the software learns about that person, the software can give automated feedback and have really a conversation with the user to try to reduce that person's risk over time. In a subset of patients, we actually had an army of mobile phlebotomists all throughout the United States, and we sent phlebotomists into the home to draw blood, and we are actually able to track basically blood-based biomarkers in a way that not only is risk going down by a calculated risk measure that we can track online at low cost or no cost, is cognitive function improving or stabilizing? Well, that's all digital. But sending mobile phlebotomists into the home of dozens and many dozens of people throughout the United States to check, well, what is it truly impacting? Is it actually impacting amyloid or tau? That's really the proof is in the pudding. So one of the key ways that we're trying to democratize access is to make it accessible to all through the comfort of their own cell phone. The other thing that we're trying to do is we're trying to bring the blood testing into the home in an even better way. Mobile phlebotomy is doable, but again, is that truly scalable? The cost is expensive. Mailing these samples on dry ice, very complicated. Spitting it down in a very specific way, mailing it to a place, a biorepository, a research site, has a negative 80-degree freezer. These are complicated things. Again, what we're trying to do is take what we're learning in the small population and then take what we're trying to refine in the lab, and we're trying to, instead of sending a mobile phlebotomist, what about sending a little finger prick card? Believe it or not, finger prick cards are used all the time for omega-3 fatty acid testing. People can check their blood and check their blood sugar. That's obviously, everyone known. You can wear a continuous glucose monitor. But there are finger prick card tests out there for cholesterol and for a variety of things that people I bet aren't even aware about. But for brain biomarkers, the technology doesn't exist at all. The problem with brain biomarkers is the proteins in the blood are in such a minuscule, tiny amount that a tiny amount of blood going into the card plus a tiny amount of protein in the blood sample is just not enough. So what we've done is we've used the newest technology to try to amplify these blood proteins and detect them in a way that's really, again, never been done before. So high risk, high reward. And basically our goal is to democratize access through software and democratize care through at-home finger prick card testing. Again, early days, but in terms of the software, we enrolled almost 1,000 patients in our first NIH-funded study. Our second study, at last look, we had over 1,400 patients, so it's over 2,500 people. Our first study was enrolled in just over 2 months, and our second study of over almost 1,500 people enrolled in 48 hours. 48 hours. Amazing.
Wow.
believe it or not, the statistics show that per site, Alzheimer's studies recruit one person per month per site across the United States. And these are studies where people have to come into the office, get a blood draw, get an IV infusion or whatever the thing is. So that's 12 subjects per site per year on average. In 48 hours, we recruited almost 1,500 people into an online software study. This is how we have to democratize care. This is how we have to bring down costs. This is how everyone, whether you're in the United States or across the world, whether you have insurance or you don't, this is the way we have to get access to brain health care. And I think we've shown that software can do that, but now we have to try to prove, can we, definitively demonstrate neuroprotective effects of what the software is telling the person to do using at-home testing. It's a big goal, it's a tough one, but we're getting closer.
So how might someone get involved in the work that you're doing? You said that there was, at some point, there was trial enrollment. Mm-hmm. Is there something going forward?
Yeah, great question. So, did I really think 1,000 people? The second study we put together was because the first study was full and we had tens of thousands of people on a waiting list. We launched a second study, and the challenge here is the cost to do these studies is actually relatively low, but when you have 1,500 people that join a study in 48 hours, the customer service aspect and the questions and all that kind of stuff gets a little challenging. So right now I'm thrilled that we have 2,500 people using our software, like literally as we speak. I can go to bed at night and I have 2,500 people that are receiving automated care based on the kind of philosophy and stuff that we've proven in science we can now translate into online education. But I'm not sure how we scale this massively without continued investment, continued scaling of the team, and the challenge here also is right now these studies are funded by research. There are no valid, foolproof ways to fund this type of care because the reimbursement paradigm in the American medical system does not account for these types of digital therapies, digital therapeutics. Germany is the most mature market when it comes to this digital therapeutic potential. But even in Germany, companies that create these types of tools and software just don't get the types of reimbursements that I think they deserve. So unfortunately, the technology is there, the outcomes are there, the innovation is there, but the medical health and healthcare system and insurance companies just haven't really caught up. Is this going to be a year or two away, 2 or 3 years away? I'm not really sure. Could it be 3 to 5 years away? Probably. So until the reimbursement path, even $20 a month or $10 a month, the return on investment for using a software solution that costs pennies could be gigantic, could be multiple orders of magnitude. But until we have some sort of reimbursement paradigm to just fund the basics, just a customer service person, to fund the technology team, to fund the big data people that are trying to look at the analyses. These fingerprint cards cost $11 a piece. Mailing, the price of stamps keep going up, but the cost of these tests are not astronomical. It's our goal, as a company and as a mission-driven company to provide the bare minimum access for free or at cost. So if someone just wants to know their single biomarker one time to figure out what their risk could be, we want to offer that at cost. That may not be like the best business model, but that opens up the doors. And for those people that have the funding to invest in their own brain health, then there's a lot that they can do. They can get panels, they can get access to more content, they can get access to more lab tests, they can take lab tests, they can go exercise in a different way for 4 to 5 weeks, recheck their blood and see, does that exercise pattern impact their blood biomarkers, does it impact cognition? People can be their own citizen scientists. If they want to change their diet, They want to, maybe they started on a new drug and they want to just get a sense of, could this drug be, helping or harming me in terms of a brain health way where other doctors and the medical system just hasn't paid attention. It's our goal to provide access to as many people as possible, but also allow people that do want to go deeper to do that.
So what is something that people have gotten wrong about Alzheimer's progression and neurodegeneration?
Our entire field got wrong that when a person is diagnosed with dementia, that's when the disease started. I was never taught, I was never educated that anything related to Alzheimer's disease and other neurodegenerative diseases that start in the brain and the body decades before symptoms. That never came across my desk. I graduated med school 20-ish years ago, nothing. I was a neurology residency program director for over a dozen years. Never entered the educational curricula about neurodegenerative disease. Start silently. Like, we just never were taught that. In the last 5 to 7 years, I think things are starting to change a little bit. But, I think what we've gotten wrong is that, there's nothing we can do. Once a person is diagnosed with dementia, they've had the disease for 30 years. But dementia is the clinical progression of the disease. There's a construct called preclinical or presymptomatic Alzheimer's disease. That means the disease has started in the brain with no symptoms yet. 46 million Americans are currently estimated to have this pre-symptomatic preclinical phase of Alzheimer's, stage 1. We were never taught in medical school or residency training about this construct. And I hate to say it, but most neurologists and most clinicians don't even think about this today. Those 46 million Americans are just walking around with the pathology building at very high risk, not getting any attention or care. So that's, I think, the big miss. The other thing that I think people are just starting to change on now, which is great after 20 years, is this earliest symptomatic phase called mild cognitive impairment due to Alzheimer's disease. It means that the pathology is building up. There are very mild symptoms that are beginning, but the person can still fully take care of themselves. The definition of dementia is when a person has cognitive changes and can no longer kind of do their activities of daily living or take care of their daily needs. But this construct of mild cognitive impairment, 20 years ago, people would say, you just got some memory loss. It's just age. It's no big deal. I'll see you back in a year. Well, no, a person that's just having the earliest signs and symptoms of Alzheimer's, that's when you need to pounce, and that's when you need to do something. And again, it's all about disease recognition. Back then, we didn't have PET scans to look at amyloid. Back then, those have only been FDA approved for the last 10 or 12 years or so. Back then, spinal taps, just people didn't do them. Back then, there were no even thoughts about blood tests, let alone actual studies in investigating these proteins. So nowadays, if someone is just starting to have the very first symptom of memory loss before dementia, like 10 or 12 or 15 years before dementia, we can now do these tests. And I think just now, the tide is turning a little bit. That's good, it makes me happy, but the devil is in the details. We really need to shift the spectrum of diagnosis much earlier. And to me, you need every day, every week, every month, every year on your side to intervene and recognizing the preclinical, pre-symptomatic phase using a screening blood test and then coming in, doing a more structured cognitive assessment. Again, one day we can do this all through software and at home. I think that's really the missed opportunity and the critical window of opportunity to intervene.
So you've mentioned diet and sleep and these other different interventions that you can track whether they're effective using these blood-based biomarkers. So far in your work, what has been the one change that people have implemented in their lives that has made the biggest difference?
Everyone wants to know, what can I do, right? If you're at a cocktail party, what are the 3 things I can do, right? Well, that's the challenge. Everyone kind of requires a different intervention based on their own individual biology. The thing that really struck me, and this is like in the first presentation that we made on this at the American Academy of Neurology meeting in 2024, it was a group of 15 people, small numbers, weren't expecting much, did some group level statistics to see before and after, how did they do? And of these 15 people, they all got very different interventions. So I believe in that group there were 2 women that started hormone replacement therapy because they were just starting to undergo the perimenopause transition. 4 people were just starting to have the earliest kind of signs of mild cognitive impairment. And those people, 4 of the 15, were on anti-amyloid drugs, 3 on a drug called lecanemab, 1 on a drug called aducanumab. There were people in there that went on no drugs at all. They just exercised, ate a Mediterranean-style diet, cut down on alcohol. One of the cases, really cut down. And then other patients had traditional vascular risk factors. We put them on drugs to reduce their belly size, their metabolic syndrome, their prediabetes and diabetes. There's GLP-1s, the weight loss drugs that everyone's talking about. Well, we use those in a targeted way, had people lose body fat, increase muscle mass. We tracked cholesterol and targeted cholesterol and then reduced cholesterol, normalized cholesterol. We used the typical anti-diabetes, anti-cholesterol, anti-hypertension drugs, and in various patients we just modified their vascular risk factors. So in these 15 patients, it was just kind of like a little pilot study. We didn't really think anything of it, put all the numbers in, the data in, and as a group, we showed statistically significant improvements from pre to post. In the past, we showed improvements or stabilization in cognition and reductions in calculated Alzheimer's and cardiovascular risk. Now, for the first time on the group level, with only 15 patients, this is the thing that really blew my mind. Absolutely not in any way, shape, or form was expecting this, like 0. At the group level, we had statistically significant improvements in both amyloid and tau protein. So when you kind of put everything together, our 2019 study, showed, improvements, not even stabilization, but improvements in cognitive function in a subset of the mild cognitive impairment patients and also in the prevention asymptomatic patients. We showed statistically significant reductions in risk. That's great too. But for the first time in humans, we actually showed improvements in the biological markers of the disease. Now, granted, 4 of the 15 cases were on a disease-modifying anti-amyloid therapy, but the majority of cases were not on any anti-amyloid drugs, and they still improved. At the individual level, that's when some of the eye-popping results really came to light too. One of our patients, Simon, that's kind of come out, talked about his story, about early 50s, 2 copies of the APOE4 variant, so higher genetic risk. His mom with dementia. He has very significant cardiovascular disease that ended up kind of taken care of pretty well. In 2019, I believe he was 49 years old, and he had a positive amyloid PET scan, meaning the PET scan showed amyloid in the brain, which is the diagnostic marker. Well, through vascular risk factor modification, lifestyle management, and other lifestyle changes and medications being used too, vitamins, supplements, etc., personalized for him, we were able to show normalization of both his amyloid and tau in 9 months. And in 14 months of treatment, when we had kind of did a baseline MRI before, a repeat MRI after, we look at the brain volumes. When you compared the MRI from pre to post, and this is just crazy to me that I can even talk about this, but it's actually true, it all happened, the brain volumes got larger over time. So you have a patient that in his late 40s had pathological signs of Alzheimer's disease. That patient was at high risk, and 2 years later, his brain volumes are larger and his amyloid and tau in the blood have normalized.
Has that ever happened before? Has there been gains in brain volume?
I've never seen this in a documented way because I've never had the technology or the funding to actually look at this in a structured way. Why isn't there funding out there to look at these things in a structured way? Because these things sound unbelievable. They're unbelievable until you see it. They're unbelievable until it happens, and then it's unbelievable until you can prove it in science. So what we've done is we've taken these small groups of people as our pilot, as our proof of principle. And what we're showing is both on the group and individual level, not only statistically significant improvements in pathological aspects, but also improvements in ways that we just weren't taught about in medical school.
So what do you wish that every other neurologist knew about your work?
Yeah, I think, this is crazy, but I feel like in the last 6 months, something's changing. In the past, I would get tomatoes thrown at me, like literally from across the room. I gave my first lecture on, how I felt that, mild cognitive impairment was a bad term, and it should be called prodromal, at risk for Alzheimer's, because no one knows what the heck mild cognitive impairment means. Like, what, impaired? They're not impaired. They have symptoms, but they're not impaired. Why is it called MCI? And then people would look at me like I had two heads, but no, really, why are mild cognitive decline? Is that a better word? Crickets, right? I think neurologists are starting to understand that maybe there is something going on here. They've just seen it too many times, whether it's a study that we've published, close to 100 peer-reviewed publications now. You have to, if you doubt something, okay, but after 100 peer-reviewed publications and actually real journals, and with media stuff and with social media and YouTube and whatever else, the message is getting out there. So I think what I'd like my colleagues to understand is, yes, preventive neurology is real. It should eventually be a recognized subspecialty of neurology. The American Academy of Neurology put out a statement that by the year 2050, preventive neurology will be a recognized subspecialty of neurology. 2050, I'm going to be way retired by then. It's by 2030, maybe 2035, but by 2030, I can't understand why preventive neurology could not be practiced in a regimented, rigorous way, as long as outcomes are studied at the same time that care is being delivered. And that's a critical tenet of our work. It's not responsible for me to practice in a clinical area where the data haven't fully been elucidated yet, or really the construct has been fully proven. So to me, I think it's incumbent upon a preventive neurology clinician to at least aim to study outcomes. But in 5 years, I'm already convinced. I know we still need to do more and publish more and really prove things in a more rigorous way. But I'd like neurologists to just believe that it's possible, and it's okay to have skepticism, and it's okay to say these are early days, because I would agree. But I would say that if neurologists had faith that you could intervene early, and that these modifiable risk factors, once modified, could actually lead to improved outcomes clinically as well as biologically, I think that's a big step forward. I also have a lot of empathy for my neurology colleagues. I have an hour and a half or more to see a new patient, an hour at least to see a follow-up patient. I mean, that's just not reality. Our medical care system is just entirely broken. Aside from being a sick care system where you have to have diagnostic codes for a problem in order to get reimbursed by insurers, there are no codes for Alzheimer's or dementia prevention. There are no, well-recognized way to get reimbursements and payments for preventative health care. There's just no incentive for it in any way, shape, or form. A person with memory loss, great. Let's order all these tests, get the money reimbursed, awesome. For a person before they have symptoms, there's nothing. There's no structure in place, and that is a major, major, major blind spot in our healthcare. I have empathy for neurologists because they have, 15 minutes to see a patient? How do you dig into the details? How do you understand a person's individual risks? How do you order tests when they're not reimbursed, when a person doesn't have symptoms? So our goal, our mission, is to democratize access to brain health care, whether it's through software, whether it's through at-home testing. I hope that the tools that we're working on can empower and really facilitate neurologists out there in the community to say, okay, I only got 15 minutes. This is the structure of things. I'm going to do these assessments. You go home, use this software. You go home, you order this test, and until this is a recognized subspecialty of medicine, I think patients are going to have to kind of grab the bull by the horns and do a lot on their own. Citizen scientists watch videos online, take control of their brain health that way. It's like shocking and sad that it has to be this way. But I think if neurologists send a positive message to patients that risk reduction is possible, brain protection is possible, but also promise not to overpromise, meaning 4 out of 10 people at risk of dementia, well, if they do everything right, they can prevent their dementia, and that's what the literature shows. But there's a lot of people out there that can still do everything right and still, develop cognitive decline. So I think you have to promise not to overpromise. But hey, 4 out of 10, 5, 6 out of 10. If 1 out of 2 cases on average may be preventable, then let's go into this with glasses half full. No promises. But I think counseling and education is critical.
So you raised this point about the fact that investors can help you to develop your technology, but at the end of the day, to truly scale it and democratize it, the problems are there, or the obstacles there are systemic. It's about payers. It's about reimbursement. So is there an ask, perhaps, that you have for the BrainMind ecosystem? Is this a write your senators and congressmen? Is this a lobbying effort? What would need to change there?
Oh boy! So we've tried to address this via an op-ed that we're kind of shopping around, and that's in process. Years ago, I spent a lot of time. The Senate Special Committee on Aging had an initiative to try to talk about these things right around COVID times, and unfortunately that just kind of stalled out and didn't go anywhere. I'm a little jaded when it comes to some of the advocacy efforts, and I hate to say that because I'm very passionate about the science, and I'm passionate about the care delivery, and I'm passionate about interprofessional education. But when it comes to advocacy, I hate to say it, I've tried, but I've struck out. I don't know that I have a perfect answer on what we can do to move the needle. Insurance companies are really not incentivized in any way, shape, or form to reimburse for preventative health care. I don't know the exact statistics, but if insurance company X spends $10,000 on preventative health care for a patient so that they don't develop a disease later, it's most likely that that patient is going to be on another insurance carrier in 5 years or 10 or 20 years, or Medicare by that time. So they have no incentive to spend the money to prevent
So you can't even make the cost savings argument because that savings actually ends up in another
You got
pocket.
it. That's exactly it. And when it comes to Medicare, that doesn't work either. Medicare starts coverage at 65. These changes need to be made in the 40s, 30s, 40s, 50s, and 60s. So Medicare can, Medicare coverage, 65. We're going to cover preventative brain health care.
Too late.
It's too late for the majority of people. So I don't fully know how to fix this problem. The lobby on digital therapeutics, like how could there just not be recognized we're not trying to make a lot of money here at scale. You don't have to charge that much. There's 46 million Americans that need this. You don't need to spend these drugs. And rightfully so, these drugs cost billions of dollars of investment to develop. So there's a lot of flack that drug companies get for charging crazy amounts of money, and I get that. I pay a lot of money for my drugs too, because not all the drugs that I need for my medical stuff, they're not covered either. So I feel it and I understand it, and it's a slog. But these IV infusion drugs, aside from being $20,000 or more a year, you have the cost of the infusion, the doctor's visits, the MRIs, the spinal taps. These drugs are really expensive. So if you can intervene in a preventative way for a few $100s, $1,000 a year, and you prevent the need for these anti-amyloid drugs or something else in the future, I'm equal opportunity. If it's an evidence-based drug, a supplement, a vitamin, a software, I don't care what it is. If it works and it's safe, let's do it. But I don't know how to incentivize. I don't know how to change policy. If there's someone out there in the BrainMind ecosystem that knows how, please let me know.
Maybe that's the ask.
Maybe that's the ask. If someone has bright ideas, and it's interesting. We published our first op-ed on this topic, give or take, in May of 2023, and we hope at some point we'll do a second 2024 or 2025. And unfortunately, there was a large section in this on advocacy, and only a little bit was left in because these op-eds get shrunk down. There was probably 1 million eyeballs that saw that, and that's amazing. Went to the #1 on Apple News, an op-ed. That's amazing. So the interest is there, the understanding of the need is there, the urgency is there, but how do you move the needle on an advocacy perspective? I don't know how to do that.
So let's end on a positive note. Tell me why you're hopeful about your work.
Neurodegenerative disease care is tough. There are tens of millions of people out there that are affected by Alzheimer's disease and other neurodegenerative diseases like Parkinson's and Lewy body dementia. There's 5 or 6 million Americans with Alzheimer's, a couple million with Parkinson's, Lewy body, maybe a couple million. That's a lot of people affected, and that's terrible, but every single one of those people has one or more family members that, unpaid caregivers that are trying to help. Our medical system is just not set up to care for people with cognitive decline. But we have truly entered a new era where we can diagnose these conditions before symptoms. We now have the diagnostic tools, the longitudinal monitoring tools, and we have evidence-based and fairly safe interventions that we can try. So I couldn't be more hopeful in the field of preventative brain health and dementia prevention. I'm hopeful because we now have the biomarkers discovered. We have simple blood tests and hopefully at-home blood tests that'll bring down cost, and we have more awareness. Before, people would say there's nothing you can do. Now people understand that there are things that we can do, and I think people feel empowered. I think people feel hopeful, and now it's just a matter of we did the science, we did the hard part, and now it's the dissemination. Implementation science is the next phase, and I couldn't be more hopeful or excited about that.